And good morning, everyone. Thank you for joining this learning series webinar, What Parents Need to Know About Opioids, Guidance for Conversations. Today's webinar has been approved for 1 EMT CEU, and American Academy of CEME designates this live activity for a maximum of 1 AMA, PRA Category 1 credit, and ANCC credit. And we have no disclosures for faculty or planners for this learning activity. Today's webinar is brought to you by the Partnership for a Drug-Free New Jersey and is being held in collaboration with the Opioid Education Foundation of America, NJ Cares, and the New Jersey Office of the Attorney General. And I thank them for their continued partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to introduce our keynote speaker who is here with us today, New Jersey Attorney General Matthew Platkin, who has made addressing the opioid crisis a priority for his office. Welcome, Attorney General, and thank you so much for being with us today.
Thank you, Angela. Thank you for having me and for all of the great work that Partnership for a Drug-Free New Jersey does. Can you all see me? I'm having some technical issues on my end, but as long as you can see me, we'll keep going.
We can see you. Yes, we can see you.
Okay, great. I want to thank you for all the great work that Partnership for a Drug-Free New Jersey does throughout the state, in particular for the Knockout an Opioid Abuse Day learning series, which our office has participated in 29 times, I believe,
Yes.
over the past several years. And we've been able to reach just an incredibly wide audience with such important information. And we couldn't be talking about a more important topic than today. Obviously, our youngest residents are always our foremost concern, but particularly when it relates to opioids. And the opioid crisis, as you all know, cuts across every segment of our society. It doesn't care if you're rich or poor, suburban, urban. It affects everybody, and it particularly has affected our youngest residents. And that, unfortunately, is true in increasing numbers as we've emerged from the COVID pandemic. The CDC's reported that nationally, overdoses of children aged 14 to 18 increased 94% from 2019 to 2020, and then another 20% from 2020 to 2021. And we know that naloxone deployments have also increased for our youngest residents. And while New Jersey's numbers, fortunately, are not as bad as our national numbers, any one death, any one overdose of anyone, but particularly of somebody who is just at the beginning of their life, is just an absolute tragedy, and it's our foremost concern. And as I say this particularly as a parent, as I think many of us are, we feel these deaths and these overdoses more acutely and personally. And we all know friends and family who have been affected by this crisis. I certainly have met with many parents who've lost their children across the state, and it just breaks your heart. And so what you're here to discuss is so critical, because making sure that our kids stay out of harm's way, making sure that we're putting best practices in place to protect them from this epidemic is a top priority, not just from our office, but for the governor and for the entire state. It's also, I think, important for us to understand that protecting our children isn't just limiting or restricting their ability to misuse opioids. So that's certainly important. Children also experience traumas or adverse childhood experiences from witnessing their own parental substance abuse, watching their parents suffer from addiction. And we have invested in programs that address those traumas as well. As many of you know, my office has led a number of multi-state settlements with the manufacturers who profited off of this epidemic, the manufacturers and the distributors. In one settlement alone that we announced early last year, we brought in $640 million just from four different companies that are going to be used to promote evidence-based treatments for the opioid epidemic. And among those programs that we're putting in place our programs in partnership with our Department of Children and Families to identify and respond to children who are suffering from traumas as a result of their parents' substance abuse, which we know unfortunately makes them at an increased risk, puts them at an increased risk for suffering from their own addiction. They also may withdraw or act out or develop unhealthy coping strategies, all of which could lead to addiction as they grow older. It's also, I think, important for us to understand the use of opioids during pregnancy and the impact of that use, and evidence-based ways to treat opioid use disorder while pregnant in order to minimize harm. We've embraced harm reduction strategies in this state. The governor has, certainly we do in our department, as well as the Department of Human Services. And unfortunately, during pregnancy, that is one area where we need to be focused and make sure that we're providing evidence-based treatment. In the second webinar that we are hosting here in 2023, we'll focus our attention on giving parents the tools they need to help children who are affected by adverse childhood experiences or who are using opioids while pregnant. We have a tremendous panel here of experts and professionals who will speak about what we need to know and what we need to do to protect our children. Dr. Ona Fofa, who is a professor and interim chair of the Department of Pediatrics at Rutgers Medical School and chief of service pediatrics and director of neonatal parental medicine at University Hospital in Newark. And as we all know, the important role University Hospital plays in Newark and the greater Newark area, providing particularly our low-income families with just tremendous medical treatment. So I thank you for being here. Kelly Moore, who is the owner of Moore Wellness and the director of the Center for Psychological Services at the Rutgers Graduate School of Applied and Professional Psychology, GISAP. And I know that school very well because my wife is actually a graduate student there. So Kelly, it's great to have you here and share your experience. And Dr. Omar Abubakar, professor and chair of the Department of Oral and I'm probably going to screw this up, maxillofacial surgery at Virginia Commonwealth University School of Dentistry. Thank you all for being here. These panels are really important. We have a significant number of people on this. Spreading awareness about how we apply evidence-based treatments to the opioid epidemic is critical to us addressing it and critical to us driving those numbers down. And we know that as we emerge from the pandemic, we have a lot of work to do. We have a lot of work to do, certainly on the law enforcement side, where we have recalibrated how we provide services through law enforcement to folks suffering from addiction and gotten away from a punitive criminal justice approach towards one that's more humane and treats opioid abuse like most substance abuse as the health challenges that they are, as well as through our Department of Human Services and this other support the state is providing to evidence-based treatment. I know from our perspective, we'll continue to provide through NJ Cares, and Kelly Levy, who's on this call, does a tremendous job in coordinating our response, a leadership role through the state to make sure that we are doing everything we can to address this crisis. I look forward to the panel, and I wish you all a very thoughtful and educational discussion. Thank you.
Thank you, Attorney General. Once again, we appreciate you joining us today. I know you may have to sign off and view this at a later time, but we appreciate your time with us today and your comments, and we appreciate your leadership on this issue. NJ Cares has been hand in hand with us over this course of this learning series. And as you mentioned, we have a great response today. We have over 1,500 people on with us to get these messages from our expert panelists. So thank you so much for your support and for being here today. Now I will mention our presenters that we have. Dr. Omar Abubakar is going to be starting us. Dr. Abubakar, you can turn your camera on because we're going to kick off with you. We have a varied panel of expert presenters as the Attorney General outlaid for us. So without anything further, Dr. Barker, thank you for being with us today.
Thank you. Thank you, Angela. And thank you for, and Attorney General, and thank all of you for inviting me again, especially with the fact that I spoke 5 years ago or 6 years ago to your group and you invited me again. That's an honor. And it makes me feel that maybe I didn't do too bad last time I was there. Next slide, please. I think what I'm going to try to do, and obviously the short time that we have, and if you see me going through the slides fast, don't worry about it, because I'll try to say what's important on the slides. We'll try to answer, are we all at risk, or only some of us, like the Attorney General, at risk? Are the only suburban? We'll answer that question. And what we all need to know, whether you're affected or not affected, and who are the most at risk. And how can we be involved as individual parents, practitioners, and professionals? Next slide. Well, my disclosure is that I have no financial conflict on the issue or the topic, but I do have an issue because I'm a parent who lost his son about 8 years ago, age 21, to the opioid epidemic. Died of heroin overdose laced with some other drugs. And within a year from the declaration, from finding out that he was addicted to the time that he died, it was less than a year. So I am not unbiased on the topic. In fact, I belong to the tribe, your tribe, the tribe to fight this epidemic. To the last day of my life, I said I'll stop talking about opioid when I stop talking. Next slide, please. This, I was going through my old, junk and storage maybe a year ago, and I run into this Life magazine cover. And this Life magazine cover says, talks exactly about the opioid and prescription medications. And that was 1966 issue. And, similar topic, doctors and the prescription scandal. And then literally 50 years later, we had the same thing. We are there. We have nothing good to show for our fight against the opioid. You see the book that's called Drug Dealer MD, written by addiction medicine physician who talked about how we were part of the problem as physicians and practitioners and doctors. Next slide, please. So first question is, are we at risk? Yes, we all are at risk, no exceptions. And I said all, we use it in the South, but I'm not using it the way it's being used in the South. What I mean is like all of us. Next slide, please. If you look at the map and how this started, 1999, they're just beginning to start. A few states worse than others. And by 2014, that's 15 years, the whole country is affected. The whole country, no exception, no state, some worse than other. Next slide, please. And who's dying? Our kids are dying. I mean, 15, this is the statistic from 2017. So things are worse now than they were before. But just show you that most of our deaths are between age 15 and 35. I mean, clearly, the majority at between 25 and 34, but this affected prior to that. Next slide, please. I'm going to use a quote from the commission that was put together at the time of 2016 by President Trump, and your former governor was the chair of that commission. And it really came up with a wonderful, historical as well as planned. What are we going to do with this opioid epidemic? Next slide. One quote from that document just got me. This came 2017. My son died 2014. But if I read this before my son died, I said, no, not me. It says every American should be awakened to the simple fact: if this virus has not found you or your family yet, without bold action by everyone, it will soon. And next slide, please. And who's us? You could see that 45% of American surveys said not they know someone who has been addicted to prescription medication, and 20% said they know somebody who died of a painkiller overdose, and 6% of family have death in their families from drug overdose. Next slide, please. In fact, the prediction 2017 is that by 2025, we'll have the fatalities from the opioid epidemic at the worst will be 100,000. Maybe maybe there's a range between 60 to 100,000. Next slide. That's for 2017. Fast forward 4 years, and just for 1 year between 2019 and 2020, 30%, and it's 100,000 people. So we reached the 100,000 people, 4 years before the prediction at 2017. Doesn't look like we're doing a good job on this issue. Next slide, please. And as you see here, we did better job collectively and as a profession of medicine and dentistry and whole profession of healthcare prescribers on prescription medication. But now the synthetic opioid, specifically fentanyl, is just shooting up worse than ever before. Next slide, please. I'll just take you back to that statement that said everybody could be affected. Otherwise, we'll catch up with you. And that prediction came to fruition 2021, because of fatality 2021 is 107 compared to 70,000 in 2017. That's a 36,000 more than we did. That means almost 50% increase this year's. That is not, we're not doing enough. And when the quote says by bold action by everyone, it meant bold action by everyone. And I don't think we have got into the bold action by everyone. Next slide, please. No, I happen to be one of those. Like I said, my son had surgery in his shoulder, 2013, summer of 2013. And I took a picture of him just so I could make fun of him with his hat at the time, because he had at the same hospital I work. By November 2003, I found out that he was addicted not only to prescription medication, but to heroin. And I suspect that even though I was not aware of it, but he transitioned from May. When he went home, the orthopedic surgeon wrote 90, I remember taking the prescription, 90 tablets of Percocet. And I said, that sounds like a lot, So I took half of it and I hid that half and said, well, just very primitive knowledge of the opioid epidemic, nothing what I know now. Needless to say, that progressed to addiction to prescription medication and then to heroin. November 2013, when he came to me and his brother and sister and said, Adam has a problem and he wants to be treated. Put him into a treatment center. Went on recovery from December 2013 to June 2014. He came out of the treatment place and he got a full-time job and went back to school. Relapsed in end of September 2014 and died. Literally less than a year from his addiction, from his disease to his death. That's a killer disease. Next slide, please. I hope none of the audience have gone through the journey that I went through, but I'll tell you it's a painful journey, because at the time I didn't know much about opioid epidemic. I knew just superficially what I know today. There's nothing we taught to me for residency, dental school, and nothing I knew on my own. So basically, I was ashamed that my son addicted. I was ashamed that my son died, and you could imagine, combine that with the grief. It's not a good combination, I tell you that. You just feel like you're in the bottom of the valley. Next slide, please. Fortunately, by blessing of the Lord, I was able to kind of figure out how to get out of this and how to get out of this. I want to know more about that killed my son. And I went to school for a year. It's an international program that between 3 universities, and I was able to finish the program in 9 months and able to get a certificate of addiction study. So I got to speak a language of addiction, or language of substance use disorder. Next slide, please. Really, to just sum it, that I thought I was missing the forest for the tree. All my experience and knowledge about addiction is the people that came in asking for more medication or had a prescription or had some adversarial interaction because of addictions. And I viewed addictions through these people, which is not the case. These are people that before they were addicted, they were normal people like the rest of us. And once they get addicted, they have a different picture. I miss that they have a disease and the disease is making them behave the way they did. Next slide, please. From that knowledge and from other activities, on my own corner, I developed a protocol to decrease the opioid analgesic and management of extraction pain. And dentists prescribe a lot of opioid better now than they did before. But I developed, with collaboration of my colleagues in other schools, came up with a program that, we're going to cut out the number of prescriptions. Next slide, please. And we came in, with a rational way of how to prescribe. Rational ways that, is this person going to have a lot of pain or just a little bit of pain? Is this person at high risk or a low risk? And based on that, the mixture, if I put it in artificial intelligence, it will come and say, oh, just give ibuprofen. I'm being facetious, but you come up with one tablet or no tablets of opioid at all. Next slide, please. And basically, we make that decision. So prescription writing is not a casual behavior of the people that I taught and the people that are around me. It's a prescription. It's a quick, thoughtful process. Next slide, please. And we give instruction to our patient and how they manage pain, just in case they forget the instruction that we give them. We'll give it to them in writing and said, if you have a mild pain, this is what you need to do. If you have mild to moderate, here's what to do. If moderate to severe, here's what to do. And if you have severe pain, this is what to do. Next slide, please. If that program put together and looked at our data, and we decreased the average number of tablets in prescription from 26 tablets to about 7 tablets. That's almost 75% decrease. And the number of people who receive a prescription from 5,335 to 1,200. That's a significant. We continue to improve it. The data is just 2019, and now in 2023, it's even better because the average number of tablets somewhere between 4 to 5 tablets per prescription. So nobody gets 20, nobody gets 15, nobody gets 12, but that's what we are. Trying to make sense of this tragedy is by making some change in the world around me. Next slide, please. My story is not my story. As the Attorney General said, this is everywhere. Unfortunately, it's American story. It's no other country as bad as us. UK is close, but not as many close. Next slide, please. And if you look, we're way up there compared to the rest of the world. Next slide, please. And if you look at the this data from 2017, if you look at the 2014 actually, if you look at the decrease in fatalities among all other countries, we're not even on that list. Italy has a decrease of 81%, and the smallest decrease was in Norway, 47%. And you see what I said is like almost 50% more, and 50% more from 2017. Next slide, please. Like I said, my story is American story. Like I said, I said, why me, God? God said, why not? Because everybody else has the same problem. This is a family that lost 2 sons to the opioid epidemic, and another lady who lost 2 sons in the same night to an overdose. And there is a mother in Massachusetts who lost 3 sons. She has 3 boys. All 3 boys are dead with opioid epidemic. This is unspeakable, disease that's just doing havoc in our country, and we're just not as bold enough, like the statement said. Next slide, please. What do we need to do? I mean, what I didn't know, I wish I knew before my son was addicted, is a lot of things, and I learned them afterwards, either through my interaction, speaking, in preparation for the talk, learning the knowledge that I learned from the meeting. Next slide, please. If there is one monumental change in the way I think, what everybody said, is that this is a brain disease. This is not a moral failing, which is exactly 180 degrees what I used to think. And that's exactly what the rest of the society, a lot of people in the society are still thinking that way. Next slide, please. In that, if it's a chronic brain disease, then it should be treated like any other illness, with skills, with compassion, and with urgency. We don't do that as much, maybe some places, some people. Next slide, please. It's a whole lot. When you're talking about a substance use disorder as an overall, including opioid epidemic, including alcohol and cigarettes, it's worse than any of the other diseases that we see every day. I talked to a nursing student who was about to graduate, and I said, and after I'm done with talking to them, I said, have anybody talked to you about substance use disorder? Just to graduate, who was May and graduating in June. They said nobody throughout the whole 2 years or 3 years of nursing Nobody talked to us. I said, has anybody talked to you about diabetes? I said, all the time, everywhere we go. So not only we don't talk about it, we don't teach it in dental school, we don't teach it in medical school, unless you're going to go inside. Not only that, but only 11%. There's no other disease that people who are affected, 11% get the right treatment. And even the 11%, it's not the ideal treatment. That's only get any kind of treatment. Next slide, please. It really, we had to pay attention, resources, and do with addiction and pay research and everything that we do with the other diseases such as cancer. We should do that because that has to change, and we have to do something similar. Next slide, please. Most of you, I'm sure, know that the substance use disorder, the appropriate term we use now, instead of addiction, we try to get rid of the language that we had inherited for hundreds of years. And it had to do, it's a disease that had 11 symptoms that we consider people affected by these 11 symptoms. And next slide, please. And it goes all the way from, craving to need to stop to neglecting. And anybody who has 2 or 3 of those symptoms considered mild disease, and anybody who has 4 or 5 considered mild disease, and anybody who has 6 or more considered substance use disorder, i.e. addiction. So addiction is reserved for that form people that are in the worst case scenario. Intervention at early age, like to do with stage 1 cancer, which would be the mild. If we do intervention at stage 1 or at risk, we would have success rate, permanent recovery, just like we do with cancer when we address it at phase 1, stage 1 or stage 2. No, SUD, we address it only when it's stage 4 at the SUD level, at 6 or more symptoms. Next slide, please. And you look here, most of our attention is in the area, most of our attention is from this point here forward, in recovery, trying to get people in recovery and keep them in recovery. Whereas we should also pay as much attention to the other arm of this disease, which is, early addictions and middle addictions. Success rate is much higher than when we get down all the way here. Next slide. And clearly, we need to look for alternative for pain medications. We need to have self-storage. We have education. I say education all the way from the middle school about the risk of drugs, education of parents, and education all the way from middle school to medical school, and everything in between. Addiction should be introduced as a disease like other diseases. Next slide, please.
And Dr. Abubakar, we're just coming to the end of your time. We have about a minute left. So I know that, you have some important tips for parents.
Okay, just skipping the slide. This is 24% of kids. Next slide, please. And there are many places people get the prescription. It's not just the doctors. Next slide. In fact, most of them for teenagers. And 4 out of 5 people who use heroin use heroin has started with prescription medication. Next slide, please. And it takes about 2 years to progress from that phase of prescription medication because it's not able to get them to become addicted to heroin or other substances that worse than prescription medication. Next slide, please. Next, quickly. The risk goes up from 3 days to 5 days to very high risk at 7 days. Treatment should not at 30 days. Next slide, please. Who are at most risk? I got to talk about this. Give me about a minute for this. Next slide, please. As you see, family history, trauma, drug availability, but the one that stands out in all the reading that I have is that age at initiation of drug abuse or drug use is what is critical in development of addiction or substance use disorder. Next slide, please. A couple more slides. Clearly, kids are not resilient. Attorney General talk about these kids having mental illnesses, their trauma at early age. We used to think that resilient. They're not resilient. Kids are not resilient. We stopped using that, and suffering mental illnesses is epidemic. We just don't diagnose it. Next slide. So if there's a trauma. If you look at how many people actually at older age get addicted, about 1 in 4 who are addicted, long-term addiction, have start using the substance before the age of 18, whereas compared to after the age of 21, it's only 125 long term. The next slide. Just a couple more slides. So kids are more likely to use it and more likely to be resistant to treatment. Next slide, please. And clearly, because of the brain development is the major factor. Next slide. Just come up with one question. So our kids, the answer is kids, our children are the most at risk. 3 more slides or 4 more slides. Next slide. Almost done. So how can we be involved? I think we have to be involved. Every one of us have to be involved, especially parents. You have to be your own advocate. You can't just take the prescription and go and fill it and put it at the counter next to the kid. Next slide. And this is an example of a lady who sent me a letter because she went to the dentist and he gave her 40 tablets of Percocet. She complained about it and she wrote me a letter. Next slide. Said, please talk to this oral surgeon because he doesn't know. Next slide. Almost done. Oral surgeon are the worst, or the dentists are the worst when it comes to prescribing to people at risk, with some of the kids under age 18. Next slide. I almost did that. That 99% of oral surgeons write opioid after wisdom teeth. Most of them write 20. They decrease now to about 60. I repeated the survey. This is 2013. And 92% of these kids are at high risk. Next slide. Next slide. Next slide. Really, I think the moral of all this is that instead of us trying to change our kids, we have to reduce the risk. We change the way we do things, whether from prescribing, from ignoring mental illnesses, from the trauma that they're subjected to. They are not to change if we don't change the way we deal with them and understand their illnesses. Next slide. Thank you very much for giving me the opportunity to speak, and I'll stick around if you have any questions. I'm sure I went through some of the slides quickly, but that's my story and I'm sticking to it. I am your tribe, and I will always be your tribe, the tribe that fight this disease, and I'll be around anytime you want to be there. Thank you very much.
Thanks so much, Dr. Barker. Thank you for sharing your personal story and also for those important lessons that you learned along the way and with your research. So we appreciate it. Just to make mention, Dr. Abubakar's slides will be available to everyone after the event as well. So you'll get a copy of those. And now I'm going to introduce our next speaker, Dr. Fofa. Dr. Fofa, welcome. Doctor, I think you may still be muted.
Okay, good morning, and thank you, Angela. I think everyone is still morning, but if I'm missing anybody who is afternoon, I say good afternoon as well. Angela and the partnership, thank you for the invitation. Dr. Abubakar, excellent presentation, and thanks for sharing your personal story. It's truly moved me and touched a deep part of my soul this morning. I don't have such a powerful personal story, but I can share that well after Angela invited me to the partnership presentation in 2016, I remember I went for my haircut and I saw an empty chair where I was supposed to sit. And there was a makeshift memorial there. And that was just 2 weeks after I had had a haircut. And the young man was my barber, who had, been found a day before. So this affects every aspect of our lives and every aspect of the society, as everyone has said this morning. I'm a neonatologist, so I'm going to try and share what we see here in my practice over the last many decades as a challenge of meeting the most vulnerable population, which is the newborn infants, and how we have approached what we do over the many decades that we've been doing this. Next slide, please. Every talk has to have an objective. So truly, the only important thing I want to comment about this slide is that the term neonatal opioid withdrawal syndrome, it's what the FDA has adopted, and though the neonatal and pediatric as well as OB literature sticks to the term neonatal abstinence syndrome. But neonatal opioid withdrawal syndrome appears to capture more all of the essence of what we need to describe, and we will talk about over the next few slides. We'll talk about the mechanism, and then the most important thing, how do we care for these babies? Next slide, please. I don't need to spend more than 2 seconds on this. These are the substances we're talking about, but let's not forget the non-opioids prescriptions. Benzos are very important, and they play a role not just on the addiction itself, but also in terms of who withdraws and the extent of the withdrawal. Next slide, please. This is a little busy, but this is not a new problem. The first set of neonatal abstinence withdrawal that was published in the medical literature dates back to 1875. And next slide, please. I'm going to categorize it and say before 1950, most of these neonatal abstinence were related to morphine use. And in fact, at that time, if you go back in medical literature, it was described as congenital morphinism. But then heroin popped its head off in the 1950s. And then the other thing that changed in the 1950s to the 60s is that there was a significant reduction in neonatal mortality. If you dig deep in the literature, as I have done, and review all of the published data, before 1950, almost all of those babies who were not treated died. Over 90% of them died. And then out of those who were treated, many of them actually died as well. The positive news over the last few decades is that now we hardly see mortality because we screen, we test, and we initiate treatment as soon as we discover the signs and symptoms. The next thing that erupted in the market, in the population, is methadone and its impact on neonatal abstinence. And then it began the journey of prescription and non-prescription opioids and the effects and the role of painkillers that you've heard Dr. Abubakar talk about. And then the last 2 decades, the impact of opioid use disorder. And of course, as this affects the general population, it impacts pregnant women and obviously their newborn babies. Next slide, please. So what has it done to us? It has really increased the, we found a significant increase in the maternal usage. Published literature cites a quadruple increase in this. And then the other thing we have seen is the parallel increase in the incidence of opioid-exposed newborn infants. When I started out my medical career in the United States in 1992, in Newark, we had a high number following the HIV epidemic of the early 1980s. But we did not see the levels of numbers that we're seeing now and the astronomical increase in the numbers across all segments of our society. So definitely it's a problem of all races. And the one thing, if you review the literature, both in the US and international, these numbers have been replicated amongst pregnant women and their newborn babies. And who is using it? Not just as we might think, the minority population, but actually it extends across all segments of our population. A very high incidence amongst our Medicaid population, amongst our rural population. Same experience they found in Canada in the published literature. And in the states, by state basis, there are wide variations, but in the New England area, in the southern states, Kentucky, West Virginia comes to mind. But New Jersey, especially our southern part of our state, is not to be left out. In Newark, we continue to see a significant amount of children who are born to opioid-addicted mothers. And this slide shows on the bottom right our rates compared to what is published in the literature. Next slide. So what does this mean for us as a group? It means there's a tremendous strain on healthcare, and most of these children, one of the things that happens in the 50s with the success we had, the decreased mortality amongst the children, was that we started treating these children early, and we started treating them in the neonatal intensive care unit. If you're interested in the history, as the neonatal intensive care became an important piece of medical treatment in the United States. In fact, some of you might recall that JFK had a baby who was born premature, who was in the intensive care nursery in the early 60s, just before he died. And not related to opioid, obviously, but because of prematurity. But in the intensive care nursery, many of the babies who utilize the NICU these days are babies that are born to opioid-addicted mothers. And in our nursery, it's about 10% of our utilization. The published numbers are 4% across the NICUs in the US. And in some community hospitals, it's up to 50% with a very high length of stay. And the other aspect of this is that it puts a tremendous burden in terms of cost. The published data suggests about $1.5 billion dollars every year. Now, the other thing I want to emphasize through this slide is this. If you review the literature, different hospitals and different parts of the country and different parts of the region within the state have different experiences. And this is truly one of the important aspects of what we still need to do as healthcare providers. Wide variation in the length of stay. Some hospitals have numbers as low as 6, and some hospitals have a high number as high as almost 80 days. Next slide, please. So why do we care? Maternal mortality is a major factor. We don't see much of neonatal mortality, but the morbidity and the length of stay is a major part. So let's review the maternal complications, and I will share with you some important aspects of what we focus on and look for in our practice here in Newark. Prenatal care is an important one. Almost every mother we see with no prenatal care has some form of history of opioid addictions or any other substance abuse. The ones that you know, if you go through the history and you don't pick on, might be the immigrant population, someone who's just new in the country. But many of our citizens that present with no prenatal care, it's a red flag. Preterm delivery, abruption, meaning early separation of the placenta, is another important one. And the other aspect of what we see is outside delivery. And this is unintended, unplanned delivery before the mother can get to the hospital. So we involve our community EMS services on what to look for and how to deal with these mothers, especially if they're born premature. In fact, we have introduced thermal mattresses as a way to make sure these babies are not cold at the time they get to the hospital, as a strategy to improve survival for these babies. The other aspect of obviously is nutrition. So food and housing insecurity is an important piece of looking at what you need to be suspicious about and take into consideration.
Dr. Fofa, I just want to tell you, we only have about 2 minutes left on your presentation, so I just wanted to,
Okay.
in case there are any points that you wanted to hit.
Okay, thank you so much, Angela. So I will go fast. Pregnancy-induced hypertension is another important piece of what we see. Next slide, please. The neonatal complications is important. 2 comments on this slide. Prematurity rate is very well correlated to neonatal abstinence syndrome. Seizures, in the older literatures, it suggests that 1 in 10 babies thereabout would have some form of seizures. The newer studies suggest that seizures are not a prominent aspect. However, infection, arrhythmia, and as well as congenital anomalies remain a significant piece of what we still see. Next slide, please. So this slide is very important because the substance and the medication that the mother takes is an important piece. So how do you take this into consideration, whether the medications are long-standing and medications like methadone, buprenorphine, or short-acting like heroin, because they do impact the timing of the onset of neonatal withdrawal. Other things that are important is associated use of other medications, as well as tobacco use. If it's methadone with tobacco use and say benzodiazepine, then we might see an increased incidence of neonatal drug withdrawal, as well as prolonged neonatal drug withdrawal. The other reason why this slide is very important is what to do. You need to begin to monitor these babies right after they're born. And most importantly, you also need to keep the babies. In our practice, even if the mother goes home, we try and maintain that mother-baby dyad. She can visit at any time, but we do not discharge the baby until the 5th to 7th day, depending on the medication, in terms of when to release the baby from the hospital because of the high risk of withdrawal. Next slide, please. So this is just important clinical presentations and the mechanism. But what is important here is the receptors are very highly concentrated for opioids in the brain and the gastrointestinal tract. And these are very important areas for focus for the symptoms of withdrawal that we see, be it the mu receptors or the kappa or the delta receptors, but the GI and the central nervous system. Very high amounts of norepinephrine release from the locus coeruleus. So a lot of the symptoms you see are related to the excessive amount of the norepinephrine. And then in terms of the serotonin, it leads to sleep deprivation. And then dopamine decrease causes hyperexcitability as well as anxiety that you see amongst these babies. Now, the other thing that is important about this, though, is that they also could mimic other problems related to problems such as infections, seizures of other causes. So a doctor, a nurse practitioner, a nurse taking care of these babies, you need to make sure that what are we dealing with here? Are we dealing with abstinence syndrome, or are we dealing with any other challenges of the newborn infant? Next slide, please.
And Dr. Fofa, we've come to the end of your time. So is there one last point you wanted to make before we go to Dr. Moore, and then we can touch on some other topics during question?
Okay, let's go to the last slide because that's a very important slide for me to share with the group. So when you look at this slide, it emphasizes what the expert committees talked about. When you have a mother beginning in the first prenatal care visit, you want to make sure you do universal screening for these mothers. Don't confuse screening with testing. We don't do, no professional organization recommends universal testing, but you need to screen using questionnaires, the 4 Ps, the craft for adolescents. That's very, very important. For the newborn infant, screening is recommended, and then we do targeted testing, and we use either the urine and the meconium. And there's also evidence that you might use human hair. But testing, we use meconium in my practice, and it's very important to understand which medication, because not all of the medications that you pick on in the urine might be because it's related to the maternal use. It might be around the time of delivery. But for meconium, most of what you're going to pick on are related to the history of usage. So the screening and the testing and the follow-up of these babies, early interventions, as well as comorbidities related to STIs, as well as other growth abnormalities, are important strategies to follow and manage these babies. Thank you, and I look forward to questions.
Thank you, Dr. Fofa. Our next presenter is Dr. Kelly Moore, and before she gets started, I just want to make note, I know we're running about 5 to 7 minutes behind schedule. So if you can hang on with us for an additional few minutes for Dr. Moore's presentation, and then that way we can get to the question and answer with all of our panelists.
Hi, thank you.
Thanks, and
Nice
welcome,
to meet
Dr.
you
Moore.
all. Thank you. I am going to try to get through all my content, and I appreciate those that can stay on. I will stick to my 10 minutes that's allotted, if that's okay. Next slide, please. So I am a clinical psychologist, and so my focus is really thinking about not just intervention, but also how we got here, and that's the work I do with a lot of my clients. So a key question that I often think about when thinking about traumatic experiences is not what's wrong with someone, but what happened to them. And this is drawn from the sanctuary model by Sandy Bloom. And this is really an upstreamist way of thinking about how people end up in difficult situations later in life. And so I'm going to think about it. A few children I've worked with that have been impacted by the opioid pandemic, who have lost parents that I've worked with. And I kind of made a composite case that can guide us through this discussion. Next slide, please. So just a quick review of what adverse childhood experiences are. Many of you might be familiar with it from other trainings you've been on, and our previous speakers talked a little bit about this, but adverse childhood experiences are a number of experiences that the people can experience at a young age. And the idea is that in the absence of an intervention or any kind of buffer, that these can lead to problematic outcomes later on in life, both from a physical perspective, but also from a psychological perspective. And the intersection between the physical and the psychological is present when we think about substance abuse. But it's important to note that, and we know this now after much research has come out of the ACEs study, of the original ACEs study, is that community environments play a large part in the risk factors for a child even experiencing adversity as a child. So we know things like systemic racism, poverty, low economic upward mobility, poor housing issues, and community violence and discrimination all contribute to the types of environments that have more stress and tend to be pressure cooker environments that can result in people finding ways to cope that may not always result in positive outcomes. And these are the environments that many of our children and families that we encounter as mental health providers are going through. Next slide. And the impact of long-term exposure to traumatic stress affects how we see ourselves and other people in the world. Next slide. So in terms of impact internally, that changes our ability to cope in a positive, healthy way, we see children's brains change as they develop. And so if you think about a dirt road, driving down a dirt road versus driving down a fully paved highway, obviously you can drive a lot faster down one of these types of roads. And in our brains, when we're constantly being activated by stress, different pathways in the brain are more likely to be dominant because they're used more often, which means they're more easily triggered and accessed. And so for a lot of these young kids that are growing up in these environments that tend to be unpredictable, chaotic, and unsafe, they kind of stay on a low level of vigilance at all times, preparing for threat, preparing for danger. And that kind of stress on the system can literally change their entire outcome on the world and changes the way they navigate through their lives, which we know later can lead to issues such as addiction. Next slide. And so that repeated exposure changes not only how we respond, but also how we cope. Because if we're constantly feeling anxious and nervous, and this is just a visual representation of that brain pathway, the road most traveled becomes the road most easily accessed. And so these children are not great at being able to perceive when they are actually in danger and when they're not. And that constant feeling of being on ready can result in ways of coping that aren't always positive, such as fighting, running away, engaging in reckless behavior and not thinking through our choices. The part of our brain that develops to help us make better choices and be less impulsive and consider consequences are sometimes underdeveloped in these children that we see that have early exposure to a lot of adversity and trauma. And that includes even those children that have chronic illness as a child and aren't kind of given the supports and education around how to manage that. And I say that from, knowing folks that have experienced illnesses like sickle cell or diabetes or other types of chronic illnesses where there's a lot of medication and education that's a part of their ongoing developmental experience. Next slide. And so what kids that are in these chaotic, unpredictable, and dangerous environments, particularly for our children that have parents that are dealing with substance issues, they learn some things about themselves, regardless of how accurate they are. When, children learn who they are from the people that raise them, and that's a mirror for them. And so if they are neglected because a parent is dealing with addiction or other types of mental health issues, they may feel unseen, unheard, and unwanted. And they may wonder if they're even of value or worthy. And we know that all children are worthy of love, but that's not necessarily how they always feel, right? And so what they learn about others is that I'm not sure who I can trust. If parents cannot be trusted, how can children learn to trust other adults? They're not great at trusting people. They're also not very good at discerning emotions in other people because they tend to be overly attuned to threat, that they see things that oftentimes are neutral as threat. And this study that's on the bottom of the slide speaks to that. With children that are in malnourished or neglectful or dangerous environments, they're not even very good at identifying the emotions on the faces of these people when lined up. And they also tend to overestimate anger and violence as a potential visual representation on the face than things like sadness or fear. And so they're over attuned and dialed into that. And that creates a lot of stress and tension on a child's body, and they're not intended to be able to hold that level of stress. Next slide, please. And again, when we have a certain mindset about our world, we tend to fit things into that narrative. It's much easier to do. This is why we see, ourselves as being, you see these polarized discussions about different things. And a lot of times that's because it's very difficult for human beings to fit new information into a pre-existing narrative without a lot of repetition and practice. So if I'm in an environment where I constantly feel nervous and scared, then a lot of things that I encounter, I will see it as something that is meant to be feared or something that I need to be afraid of and kind of buff up against and try to fight against. Next slide. And so the impact of substance use dependence on families and children it can have this long-term effect that can even spread across generations. So we know that adversity in childhood can lead without any intervention to a number of issues, including substance use issues, including suicide risk, including depression, reckless behaviors, and other physical ailments like heart disease, diabetes, and other things. But part of it is that we see a young person in front of us, but we don't know all of what's going on underneath the surface. And so a lot of times what they're doing is trying to find a way to cope. So they may self-medicate, they may engage in fighting and other things that I described earlier. And with ongoing exposure to that and then adoption of behaviors, What are they doing? They're growing up, they're having children, and then they're continuing to model these same strategies that are maladaptive for coping. And then their children also are seeing that. And that's how we sometimes see that intergenerational pattern of substance use dependence and trauma in these families. Next slide. So what can we do? And I'm squeezing together what could be hours or semesters worth of information into a short period of time. So I thank you for understanding. But in thinking about how you survive, we do things to meet those needs for safety and security. And we do this all different kinds of ways. For some part of the population, they may choose more creative, positive, adaptive ways. For others, the other ways can be more maladaptive to the system, including self-medicating and self-soothing. Next slide. So what I talk about a lot with folks I work with is around this example of corrective experiences, because we know that we cannot change someone's life just because we are their therapist or their provider or their teacher or even their parent. Sometimes our kids are going through a lot of things. And so we have to think about where we have the most control and where we can offer them more predictability, control, and safety, but also recognizing their pain and being able to use nonverbal communication in addition to that in the time we're with people to make them feel safe. Anywhere we are, whatever lane we occupy, we want to encourage safety, predictability, and offer control. So much of how people react to traumatic experiences and even the idea of engaging in the use of substances is often impacted by who's around and who are they feeling safe to talk to. And sometimes we are successful in those endeavors and sometimes we're not. But where we can be, we have to be able to feel like we've done everything we could, right, while they were still here to be able to offer them that. Next slide. So it starts with us in our workplaces and where we encounter people. So a lot of places are embracing the screening for universal screening for exposure to trauma. It doesn't have to be an ACE screener, but I think what you do when you do some kind of trauma screening is you're making it known to the people you are interacting with that you're comfortable talking about traumatic things. So many people don't like to ask because they're afraid they're not going to know what to do. But the truth is that just by asking, you're letting someone know in a very indirect way that you're comfortable with hearing about their experience. But also screen for resilience. All of us are born with positive traits and have strengths. Even a child that talks back a lot and is difficult to interact with, they have a strong personality. How do we grow those strengths and not snuff it out, but also recognize how we can move it and nudge it into a way that's positive and really use their positive attributes to work with them. And also treating every person that we encounter as if they've just had their worst day is very important. So you can follow your protocols based on whatever role you serve, whether it's law enforcement, educator, provider, whatever it is. But the truth is that if we treat everyone as if they're having a really bad day, we're more likely to enter that encounter with compassion, composure, and empathy for the other person. And the last thing I think that I want to mention is that villains are made, not born. And so when we see people making choices, and we've seen hundreds of people that are dealing with this issue, and it feels like it's a never-ending revolving door, continue to remind yourself that these are not choices that are being made in a vacuum. There are experiences that predate that person, and it's really important to lead with compassion and know that just as we can make something, we can unmake it. And it's small steps towards that change. So giving yourself grace, but also not becoming jaded in the work, because that compassion fatigue is very real. Next slide. I'm going to go to the last slide. Sorry, next one. So James Baldwin, one of my favorite authors among many, but I love this quote that he has, and it says, not everything that is faced can be changed, but nothing can be changed until it's faced. And so when we think about adversity in childhood and how it can lead to some of these issues that we've been hearing about today, awareness, acknowledgement, and tangible change in all the spaces we occupy are really important to moving towards creating these corrective experiences for our children. And so as parents, one of the things we can do is really talk to our children from a young age, really teaching children from a young age how to make choices. That's something that parents miss a lot. They're so busy making choices for their kids that they never teach them how to make decisions and how to endure the natural consequences that come with that. And I'll just use a quick example from my last point. I have a child with sickle cell disease, and actually right now this week, he's been dealing with a pain crisis. And he's had a very mild course of the illness, but he was home from school the other day, and there's something fun happening today at school. And he really wanted to go. And so at the age he's at, which is 5th grade, we had to make some choices and have some conversations. And so one of the things we said is that if you go to school, there's a couple things that could happen. And we laid everything out and we asked him to then make a decision. And so his decision was not to go to school today. But if he had decided to go, I think I'm pretty sure we would have gotten a call saying that he's not doing well. You need to come and get him. And that would have been the natural consequence. But that's an example of how important it is at young ages to really make sure we're teaching our children, laying out consequences, laying out what the choices are, and then sometimes either helping them to make the best decision or helping them understand the consequences if they do decide to make the wrong choice. And so I'll end there in respect of time. I know we went over, but I do appreciate those of you that were able to stay on.
Thanks so much, Dr. Moore. Such important information that you shared as well. And I know that we are coming to the end of our time, but I do want to pose a few questions to our panelists. Dr. Fofa, Dr. Abubakar, and Dr. Moore, if you could come back on screen. Just for one final thought. We have a lot of parents who are on with us, but we also have professionals. We have a lot of school nurses who are with us today. We have prescribers. We have, doctors and dentists. And so I just want you guys to just leave one thought with, with our attendees. So we'll start first with, if there was one, piece of advice to give to the prescribers, it's how would they best interact, or what advice would you give them to best work with their care team to address the issues that we discussed today from your perspective? And Dr. Moore, we can start with you.
Yeah, so one of the things I talked about towards the end of my presentation is the importance of giving choice. And I think it's underestimated how important it is that we tell people what we're doing when we're interacting with them, and also so that they can anticipate. There's a lot of fear in engaging with healthcare providers in particular. And so it's very important to say, okay, this is what we're going to do today, setting forth the agenda, even if you're going to be with them for 10 minutes, right? Telling people what you're going to do, asking if they're okay with it. If they are not, what will they need to feel okay about whatever's happening in the encounter? And even as parents, we can do that too. Letting your children know what the schedule is for the day, what we're doing today, what the plan is. Predictability, routine is so critical to feeling psychologically safe. And I think it's a very small thing that's underestimated in its value.
All right, thanks. And Dr. Abubakar, for your fellow prescribers, as they're working with their care team to address these issues of this epidemic and the rising levels that you pointed out, including diversion and signs and symptoms and prescribing, what would you say?
Thank you, Angie. I think I have one kind of statement about the whole issue is that we have to remember that substance use disorder is a self-medication for undiagnosed, unknown, or untreated mental illness of some form, of some capacity, including all the issues that Dr. Moore mentioned. They fester and they become illnesses that is under the surface, and opioids seem to have their way into making the patient feel like it was treated. As far as pain management, I think whether you're an oral surgeon, dentist, or orthopedic surgeon or primary care physician, the first line of treatment for pain medication nowadays should not be opioid. It should be prescribed, scheduled, non-steroidal or Tylenol or combination of both, interchangeable or together. That should be the first line of treatment. In my practice, everybody get a prescription for 600 milligram or 800 milligram of ibuprofen on a scheduled basis, and then a backup in some instances, some patients that I identify at risk, like when we talked about, I tell the patient, we're going to avoid narcotic, and the family very open to it. In some patient, I write it and I say, don't pick it up from the pharmacy. Use these 3 or 4 choices, and if that doesn't work, then you come back. And I think the last thing I was going to say is, as a parent, because all the doctor's treatment for pain, especially acute pain, it's not an evidence-based that based on data in the past, that's 3 days or 5 days or 7 days or 30 days. None of that's evidence-based. It's just articulated by a pharmaceutical company. Therefore, as parents, you'd question, you have the right, in fact, you have the responsibility. If you take your kids to a doctor and they give you an opioid prescription, you need to sit down and say, can we have a discussion about this? Can I use something else? It's so important. Addiction is a pediatric disease, and it starts there. And I think the only way we could minimize it is have the parents involved. What is the number of narcotic tablets safe? For some patient, 0. For some patient, no more than 5, 6. Thank you.
Thank you. And Dr. Fofa, the same question to you for your for other prescribers, health practitioners who are on with us today. What advice or last thought would you like to leave with them?
Oh, thank you very much. Again, thank you to the panels, as well as Angela and the partnership. The one thing that I'm going to reiterate here is that pain is an important piece of what we have to care for as physicians, and no patient pain should be unaddressed. However, the strategies are multiple and variable. And I like Dr. Abubakar's statement about starting with the simple analgesics. The one thing, though, from my patient populations, the pregnant women that I see and care for and meet on a day-to-day basis, it's important for them to hear from us that we are going to approach them in a non-judgmental manner, and let them know that it's important to maintain the maternal baby dyad. That relationship, it's important to be maintained for the long-term a good outcome of the family.
Thank you. Yes. And so one last thought. I mean, obviously, today's presentation is, guidance for parents and what parents need to know. With that in mind, I know some of you already touched on that, but Dr. Moore, I'll go to you. One last thought on today and all of the presentations, and a message to all of our attendees.
I think for parents, we do the best we can, right? I always tell parents, we'd like to think we can control our children. We cannot. From the time they're born, they're kind of controlling us, right? So I have 3 boys. I do everything I can. My husband and I, we do everything we can. But at the end of the day, we cannot, we have to give ourselves a lot of grace. So we put everything we can into raising them and trying to help them make good choices. And then, the rest of it, we have to kind of leave to the universe, right? And so I would say to parents to please be kind to yourself. And, as long as you feel like you're doing the best you can and getting the support that you need, then you have to kind of, make sure that you're giving yourself grace, even if things don't always go the way we want them to.
Thank you, Dr. Moore. And thank you again for being with us today and for sharing all of that great information, as well as a reminder for parents, for practitioners, for professionals who are on, to give yourself that grace. I think that's a really important message for all of us as we deal with this crisis that continues to impact so many. So thank you. And Dr. Fofa, I'll go to you next. Last note that you want to leave with our attendees?
Again, caring for children is a complex. Many times we have children who are nonverbal for whatever reason, be it age appropriate or be it because of developmental challenges. How do we approach them and make sure they comfortable preoperatively. I saw a question earlier about how do you deal with cancer pain. It's important for the families to know that we take pain as an important piece of the vital sign. And we want to make sure that we approach and treat these patients in the most appropriate and safe manner.
Thank you. And thank you, Dr. Fofa, for joining us today and for the information that you shared about our youngest, the youngest and the smallest of the victims of this crisis and this epidemic. So I appreciate you being with us today and the information that you shared.
Okay, thank you.
Thank you. And Dr. Abubakar, I'll give you a moment to give us our final thought of the day with all of our attendees. So
I think more for the parents, obviously being a parent myself, we need to remember and maybe teach that frontal lobe of the brain is not completely developed until the age of 18 to 20. And nowadays there's some data to say until 25, even 30. And as a result, as a parent, the frontal lobe of the brain is the what control, decision-making, judgment, all the appropriate things. So, and you think about it, is that it's the brakes that we have to make when doing things. And until then, the parent's going to be the frontal lobe of their kids. If the kids waited, if God wanted to have the kids born with the frontal lobe completely, they won't be able to get out. They have to get a C-section, everybody. So they postpone, or nature postponed the development of the brain until age 18. And no wonder we historically throughout civilization, 18 and 21 are monumental numbers. And we rear our children until longer than any other species. And we should rear them with kindness, with understanding that we can't change them. All we have to do is just protect them and guide them to the right place. And I think we need to keep that in mind as parents and be compassionate, with ourselves and our kids. Thank you.
thank you. And I want to thank again all of our panelists and the excellent information they shared. I also want to thank all of our attendees. I know we have over 800 of you who still stayed on with us, going over close to 20 minutes. So I appreciate you continuing to stay with us. And I am seeing in the chat an interest in a part 2 of this discussion. So we'll definitely take that into consideration. Again, thank you to Attorney General Platkin for joining us today. His leadership and the leadership of NJ Cares on this issue in New Jersey, in the state of New Jersey, cannot be understated, or overstated rather. So I really appreciate their participation and partnership on this. Thank you again to all of our attendees, and have a good day, everyone. Be well.